Thanks, Jared. We appreciate your time. Why don't you start by maybe introducing yourself and then telling a little bit about your practice and then maybe talk a little bit about tops and then we'll field questions.
Absolutely. So thank you everyone for having me. Pleasure to be here. Uh, I'm a neurosurgeon based in Los Angeles and uh, do brain and spine surgery, but the majority of the work that we're doing for the last decade has really been around motion preservation. Uh, I'm very fortunate to have trained with some amazing people on the East Coast, Columbia and at Harvard, and then on the West Coast at UC Davis and at Cedars-Sinai, um, around this concept that, fusion just doesn't make sense. I talk about this a lot at professional meetings and podcasts, but the concept of taking a motion segment, important like the spine, it's designed to move, and treating a problem by fixating it together doesn't make biomechanics sense. But also, we've looked at while you can treat a problem because sometimes pain does come from motion in the setting of degenerative stresses, it really is a band-aid fix. It's a nonsensical fix because you maybe take the pain away at that index level initially, but when you start fixating joints and segments together, I always use this analogy like a car. You have four shock absorbers on a car. If one of the shocks goes and it's not working anymore, you can, very easily drive the car, not comfortably, but what happens to the rest of the shock absorbers? They wear and tear with time because we have lack of symmetry. And what we've noticed in the spine, throughout the spine, especially the cervical and the lumbar spine, the neck and the lower back, is that the motion segments in and around a fusion work harder. They wear faster. And so while a fusion at one level may fix pain, may fix a problem, it creates a cascade of problems down the road. And so, the spine surgery has kind of been a bad word in medicine because in many ways, due to fusion. One surgery begets another surgery begets another surgery. And so we've been doing a lot of work in the artificial disc space. And then I was fortunate to be involved with Premia on the TOPS trial, the FDA trial, from the very beginning. So the wonderful thing about our exposure and our experience in our practice is that I actually have patients, even though it's only been approved for a year and a half by the FDA, I have patients that are following up in my practice that have had TOPS, placed by me 6 years ago, 5 years ago, 4 years ago. So it's really nice to have that experience and have been part of the trial. And we've now done, I think, more TOPS than just about anyone. But we also have pretty strict indications. We definitely do it for the right reasons. And one of the things I wanted to talk to people about is kind of why. What is TOPS? What is an artificial facet replacement? What is it replacing from a anatomic standpoint? But also from a kind of a convention standpoint. What was the standard of care and why? And how is this superior? So just to get, I don't know if anyone has any questions yet. Ron, I can't see people. I can just see you. I don't know if that's done that way for a reason.
Correct. So if anyone wants to pose a question, there's a Q&A icon at the bottom of the page, and you can just type in a question and I'll read it to
Perfect.
Jared.
Perfect. So, there's a few things to understand with the spine, right? And the easiest way to look at it is an anterior, the front side of the spine, and then the posterior, the back side of the spine. And the back side of the spine, you put your hand on your back, that's the part you can feel, right? That's the spinous process. That's the part that sticks out. Okay. And the front side are where the discs and the vertebral bodies are that a lot of people can recognize, recognize by on pictures. It's a very kind of common look. We're not going to talk today about the discs or the front. We're going to talk specifically about the back. Now, in the back of the spine, we have the spinous process that you can feel if you put your hand in the back, and you have the facet joints. Now, the facet joints are important, like the discs. The discs offer kind of a shock absorption, movement, range of motion. But in the back, these facet joints also are moving and articulating like a joint in the rest of the body, like a hip joint or a knee joint. And again, I'm not an orthopedic surgeon, but what I know of hips and knees, no one's fusing them together. anymore, right? That's not considered the standard of care. That's heresy, right? Today, you get an artificial knee, you get an artificial hip. Yet, 40, 50, 60 years ago, before these technologies were commonplace, people were fusing hips and knees together, which, as you can imagine, drastically changes your quality of life and your function. And so today, we are looking at a very unique solution to a very common problem. When the facets in the back of the spine become arthritic, this could be from trauma, from age, from genetics, there's lots of reasons. When they become arthritic, they tend to grow. And they grow, the growth is the body's way of actually trying to stabilize, to make a unstable or a difficult problem safer for you. Problem is when they grow, they're growing into the central part of that spinal canal or the sides, which is where the nervous system is, where your spinal cord that usually ends at L1 or L2, and then the cauda equina, the nerves dangle through, but they can be compressed or hurt or impinged upon by the growing facet joints that are your body's way of trying to stabilize. And this is even more true in the setting of something called spondylolisthesis, where you have a slip. And that slip, if you can imagine, the facet joints are even working harder to try to pull you back, to try to stop that slip from happening. Because if you can imagine, if you're the spinal cord or the spinal nerves traveling through the center and there's a slip, that can cut the nerves off. They can cut the transmission pathways off. And so in the setting of a slip, you can have stenosis, tightness on the spinal canal, on the nerves that are exiting. And the only solution we've really had up until now, has been threefold. One, conservative care, do nothing surgical, do PT to get your core stronger to try to help prevent that slip, certainly has a place. Injections for pain, acupuncture. We have a functional neurosurgical practice. We believe in meditation, virtual reality, holistic. So we absolutely believe in all of that. The problem is, when is the right time to pull the trigger? Right? Because the body's way of telling us there's a problem is pain. So we can treat the pain. But if there's an anatomic problem that puts our nervous system at risk, that's when I get involved. And that's when I actually don't fool around with non-operative measures because I don't want people to injure themselves. As a neurosurgeon, I want to be a steward of your nervous system and protect you. And so that's kind of the context and the setup for where this technology evolved from. I saw there were some questions around. Should I stop and try and field some of those?
Yeah, let's do that. Maybe I'll try to group them a little bit so we can try to hit a bunch of them in an efficient way. So one of the questions is osteoporosis a contraindication? And in general, what are the contraindications for TOPS?
Sure. So, osteoporosis is a tricky one because during the original FDA trials for all of these things, even fusions for our discs, for tops and facets, osteoporosis was usually exclusion criteria as opposed to osteopenia, which is usually okay. Everyone has different criteria going into these trials. But, surgeons like myself, we're kind of we really do push the frontiers to try to give people the best possibility for success. And so there are many ways that we deal with osteoporosis. I can tell you that it is considered a contraindication if you have true osteoporosis from an on-label standpoint with the FDA, but we do a lot of things off-label. So we have ways of actually putting the screws that anchor the tops and cementing around them. So osteoporosis for me is not necessarily a contraindication. It can be. Every patient is different. I look at it very carefully. The one thing that's important in this answer is not to be surprised by it, right? Surgeons need to know ahead of time if that's something that we have to contend with. In general, though, it's a little bit of a riskier approach with osteoporosis, yes.
If I had bone on bone in the anterior column, is that a contraindication for TOPS?
So I'm not allowed to talk about this, but yeah, so it is a contraindication for TOPS, but we're currently the only site now in the country and possibly the world that's running a 360-degree artificial disc plus TOPS trial. And that's something I can address offline and table it later because it's a very unique trial that's not really pertinent for this discussion.
How about if I've had a previous laminectomy? Am I potentially a TOPS candidate, or does the laminectomy
Yeah.
rule me out?
No, absolutely. So if you're a prior laminectomy patient, you could be a great candidate for TOPS. But I will say that you want to make sure you're going to someone who you feel very comfortable with, who has experience in revision surgery, because it certainly increases the risk of a spinal fluid leak, of nerve injury, because there's going to be scar right in the area where we're working. But often I've actually had many patients who had prior laminectomies. And the problem is that if you do a laminectomy, even if it's done well, but often it's done pseudo well, those facet joints become a little bit more incompetent. So while it works initially, over time, you can have increasing slip, increasing facet arthritic growth, arthropathy. And so these are actually patients that can be great candidates because the laminectomy is no longer sufficient and they need the facets to be removed and replaced by the tops itself.
What if I've had a previous L4, L5, and L5S1 fusion, and now I've got a problem at 3-4? Can you put a TOPS at 3-4?
Yes, absolutely. There's actually an approved device that kind of connects your old fusion to the tops above. So it's certainly something that we have done, and I've done it now, many times. We're on, you're muted. You're muted.
Sorry about that. That patient had two successfully fused segments and an issue at the adjacent level. Another patient is asking if I come in with two level of disease, let's say a spondy at 3-4 and something else at 4-5, and I have a slight amount of scoliosis, is that something you can treat?
Absolutely. Yeah. So unfortunately, the tops, just by its design, and by, per FDA approvals and testing, it's only ever been done on one level. We have no current technology to do tops at two contiguous attached levels. We could do it separate levels, but we do need anchors for the tops device in its current design. So we can't stack them per se, but I have many times done like a little micro or endoscopic laminotomy or discectomy at a different level, and then done up tops at another level. I've done artificial discs at one level, tops at another level. So that really just depends on your anatomy and what you need, but certainly can be dealt with.
Yeah, this patient has had two-level cervical fusion. Now they have stenosis and spondy at 4-5, L4-5. Does the fact that they have had a fusion in the neck area give you any reason for pause in treating their lumbar spine with a motion preserving device?
Great question. The only pause is that I wish that I had got to them first and did an artificial disc in the cervical spine. But, no, it absolutely would not affect unless there is major alignment issues or scoliosis issues, which can happen around fusions, would not make me consider that a TOPS was in any way contraindicated in the lumbar spine.
Okay, and then another patient asked, can you use TOPS in the cervical spine?
Yeah, it doesn't exist.
Okay, fair enough. Um, there's another patient who's talking about a bilateral lytic spondy at 5-1. Would you operate at 5-1 with TOPS? And would you operate on a lytic spondy, let's say at 4-5? So let's talk about lytic spondies and let's talk about 4-5 separately.
You know me, which is why you're breaking them up. But so the answer to the question is, in general, these are off-label indications. But yes, so 5-1, it was not part of the original FDA trials, and it poses some nuances that are still being looked at. In my practice, we have done many tops at 5-1 with great success. But again, I want this was not part of the trial. So my long-term success with tops, which really has been, I haven't revised one of them during the trial, was all on label with per the indications of the FDA trial. So meaning the only 5-1 L5S1 TOPS patients that I have only been since the approval, which then gives me the authorization to use things off label. Because as surgeons and doctors, FDA says it's very clear that we can do that if we see it's appropriate. Like half the medicines that people prescribe, for example, gabapentin, is prescribed for nerve pain, for neurogenic pain all the time. It's not approved for that. Gabapentin is approved for seizures, and yet it's never used for seizures anymore because it's considered not a good seizure medicine. So the 5-1 for me would be on a case-by-case basis, depending on certain things. And then for a lytic spondy, it's sort of similar. We have to figure out if it makes sense and how unstable that lytic spondy is, because you're asking that TOPS potentially to do a lot. But these are all kind of more off-label indications, and I've done it for both with success. So the only caveat, and I'm a researcher, so this is very important to me, the success is very early, right? We don't have 5 or 10-year data on those indications.
So we talked previously about a patient's had, let's say, a previous laminectomy, and then you're coming back in and you're treating that patient with the TOPS because their disease has progressed. A patient is asking how challenging is the scar tissue when you have to go into the same location where someone else has already been?
Yeah, I mean, the answer is it's challenging. I tend to be, for whatever reason, just based on my location or the experience that I have, kind of a person that gets a lot of these revisions. People come to me asking for help, or I just got a call right before this that there's someone has a complex fusion that's fallen apart. They need someone who can fix it. So, and I'm not the only one. So it's not just patting myself on the back. It's just experience and knowing how to find someone who has that exposure to revisions and complex surgeries. It's complicated, but every patient's different. I've done revision surgeries and they went so smoothly, the scar tissue just kind of fell away. And I've had other patients that we were working, as a neurosurgeon under the microscope doing microsurgery to do it safely. It's a case by case. A lot of the imaging can help us, but honestly, you don't always know how hard the revision will be until you're in there in the operating room.
Okay. And again, another question that's similar to what was asked previously, but it came from 2 additional patients. Both of these patients had a previous fusion at 4-5. One of them now has adjacent segment disease at 3-4. Another one has adjacent segment disease at 3-4. And they're actually being recommended for a fusion from L2 down to L5. Apart from extending a single level fusion to a 3-level fusion, what other options are there surgically at these different levels that you see potentially? Obviously, each patient is different, but what are the options that are
Yeah.
out there?
Yeah, so I mean, and I appreciate all these questions, and I'm always, I think you're going to show my contact information. I have a lot of Instagram, and people reach out to me. I can answer the best I can, but everyone's different. The images are different. There are options. I try to avoid these long construct fusions whenever possible. The only time I've ever done of late long construct fusions is in trauma situations where there's frank instability in the spine and there's a risk of spinal cord injury, or very complicated scoliosis with very severe curves. Even in the world of curves and scoliosis, we're doing trials and kind of doing very experimental work with patients who understand that and have consent and ethics approval to look at kind of novel ways to avoid long construct fusion. But in general, something like a 1 or 2 or 3 level, there are often ways to avoid it. We are looking at combinations of decompressions, endoscope, artificial disc, TOPS, trying to keep motion preservation at as many segments as possible, because that clearly has a correlation to longevity of spine health. We're not just talking about the segments in question, we're talking about your spine health as a whole. And that's a really important concept that I want to convey to the people who have kind of logged in for this. It's not just treating the problem. You have to look at the whole spine, you have to look at the patient's body, activity level, work, all the demands on that spine, and how to best treat it from not just the moment in surgery, but long-term to avoid a future surgery.
Do you think that putting the TOPS in the back of the spine to replace the facet joints is going to put more strain on the disc?
So, it's a great question. We all thought that when you, Ron, and the company kind of presented this technology, and do you want to be part of our trial? And it's a formal FDA trial. We all were worried that the disc would blow out over time, and that the TOPS would be there doing its thing, but the disc would blow out. Honestly, we haven't seen it, which is great. And so the idea is, and I'll use the model just to show you. I mean, this is kind of a cool model because you can see there's a fusion device on the disc space up here. So this, where the bar and the rod is connected between the screws, there's no motion, right? And so that's your fusion. Down below is your TOPS. They have similar screws used as anchor, just because of familiarity of the placement for surgeons, but they're not connected to each other. So this TOPS device is actually moving. right? And so the idea, and from what we're seeing physiologically over now several years of doing this, is that if the TOPS is placed correctly and the surgeon does a good job, and it's the right indication, that TOPS is working like a facet joint posteriorly. So it really has no bearing on the wear and tear of the disc. The wear and tear of the disc will be the natural wear and tear of the disc that you would experience anyways, right? That's the idea, is that that posterior segment, this TOPS, should work together with the front, the disc, like it would normally. The one thing I love about motion preservation surgery in general is the same concept when we go into the brain. You try to disrupt the normal anatomy as little as possible. And so when, as a surgeon, when you leave, if that TOPS device is working, it should be working synergistically with the disc space, like it was meant to, like a facet was meant to. While it's not a magic injection that regrows your facet or a magic injection that regrows your disc, these are the best things that we have to date to replace the functional unit. And so that's how we're looking at it.
How long do you stay in the hospital after surgery?
So, we're about to publish a series. I think, Ron, correct me if I'm wrong. I think we've done more outpatient TOPS than I think anyone else.
Yep.
And so we actually have patients. We're very good these days with our anesthesiologists, and when we're there doing blocks, so we can do these very fancy blocks. So you actually don't feel any pain or much pain for the first 24, 48 hours. Then you hurt. And I do get calls from patients, but for them, I've had a lot of success doing this as an outpatient. I've had patients who stay in the hospital 2 or 3 days. Most of my patients, especially the ones that are motivated to be outpatient for a lot of the kind of infectious risks and benefits of just being at home, tell me that they're not very happy with me for the first 5 days. They're uncomfortable, they're sore, but it's tolerable. And the biggest problem is the positional changes, getting in and out of bed or from a chair. But once you're up and walking, the musculature, especially in the back, which really hurts from spasm, calms down and it's much easier. So the first 5 days, I had one patient kind of laugh that I was wrong. It was 6 days. And I had another patient that said, no, they were great in 4 days. So it varies. But by that first week, when I see you in the office post-op, people are like, we turned the corner. By 2 weeks post-op, I have a lot of patients that go back to work. A lot of professionals, surgeons that I've operated on, say they start seeing patients 2 weeks post-op and are even able to operate by 3 weeks post-op. So it is actually a pretty fast recovery if you compare it to fusion, for sure, because all the recommendations around bending, twisting, and lifting, none of this, wearing a brace that goes hand in hand with the fusion, I don't do that to my patients at all. I actually say this is a motion device. I want it to move. It is like Newton's law. Things at rest stay at rest. Things at motion stay moving. And the body is inflammatory and I want things to move. So while I don't want you to be doing acrobatics your first few days, I want you to allow yourself to heal. I do want light motion. I do want walking. I do want movement. And so the recovery, in my experience, and the trajectory is much faster than fusion.
I have two interesting questions that are somewhat related. Let's put them both together. If I have a foot drop, is that a good indication potentially for TOPS? And along with that question, another patient said, if I don't have pain, but I have like a dominant numbness, is that potentially an application for TOPS?
Yeah, so both great questions. So regarding the foot drop, I'm sorry that's what you're going through. I mean, honestly, when someone comes to me with a foot drop, it's almost too late. Like you have neurologic injury at this point. And I don't want to say it's too late to be discouraging because I've been wrong. And I admit that. I've actually taken patients um, to the operating room with pain or other symptoms in the context of an old foot drop, year or 2 year old foot drop, and remarkably have seen improvement. Now, the problem with foot drop is it shows already damage to the nerve. It is impossible to know after a TOPS procedure, which you may be in, it may be absolutely appropriate, just from an anatomic standpoint, to try TOPS. And I wouldn't know that without looking at images. An exam is helpful, but I would say the majority of my patients are out of state or international. They come in to see me, and my office takes care of all of that. So the exam is fine, but Zoom is very good. The images will tell me if you're anatomically a good candidate in the setting of a foot drop. What I can't predict, and I just need to make sure people understand this with respect to expectations, is when you already have neurologic injury, and this is also numbness. So that's why you kind of, Ron, combine the two questions. It's very different than pain. It's impossible to know how much something like a TOPS will help. The goal of surgery at that point, TOPS or any surgery, in my mind, is to prevent things from getting worse, with the possibility of getting better, but the better can be quantified on a 0 to 100 spectrum. It can be none, everything, or everything in between. And it is impossible to predict that level of recovery. So I would say make sure that whoever you're consulting with is really honest about the limitations of the kind of crystal ball prediction prognosticating of what will happen in that setting.
A couple questions about scoliosis. One person has slight scoliosis, another person has severe scoliosis. Where do you draw the line in terms of scoliosis with TOPS?
Okay, so per on-label indications, usually anything we could try to stay below 10 degrees. But in our current trial, where we're looking at using artificial discs and TOPS together, we've actually limited that to 20 degrees. And again, that's off-label use. So it depends on the patient's anatomy and needs. But in general, for on-label tested use, it's less than 10 degrees in the lumbar spine.
If I'm 85 years old, but I'm active and healthy, would you operate on me?
If you needed a surgery, if
Okay.
you're
I
active and
mean,
healthy and
I think the
having a good
question has
life,
to do
then
with the
no.
age. Well, how do you
Yes.
look at age?
I'm joking. Yeah. So age is people, I get this question all the time because I think I don't know about TOPS, but I've put more cervical and lumbar artificial discs in 70 and 80-year-olds than most people. Maybe than my mentor has probably done more than me at Cedars, because age really is just a number. There we have good data, right? You have to look at bone quality and osteoporosis, but there is phenomenal data. There's data published in the New England Journal of Medicine, one of our preeminent journals, that shows age is a number. There's actually better metrics, something called the frailty index. There are certain scoring metrics now, depending on what your overall health, your quality of life, your activity, your tolerance, your activity tolerance, that is a much better predictor of your ability to successfully go through a surgery. So if you're in need of a surgery, I don't let age in any way prevent me from offering that to you if I feel you're a safe candidate.
Okay. Um, so this patient was wondering whether if you put a TOPS at 4.5, what would its impact be on 5.1? As opposed to, let's say, having a fusion at 4.5, what do you think the impact would be at 5.1?
Yeah, I mean, so that's a great question. That we bring in the concept of adjacent segment disease, right? And so the idea is, if we can preserve, I mean, if again the surgery has to be done correctly, you want to preserve the facet capsule, not overdo the dissection. There's some nuances there, but the concept is that if you have a fusion at 4.5, the data varies all over the world, but in general, 1 in 3, 30%, some people say 50%, but it's closer to 1 in 3 patients at 5 years have clinically significant, not just radiographic evidence of adjacent segment disease. And so, you have a really good chance if you have a 4 or 5 fusion of needing another surgery at 3.4 or 5.1. And so the idea is that the TOPS device, by preserving motion at the 4 or 5 segment, reduces that significantly. How much? Also, the data varies. Most of the data we've looked at suggests, and this is difficult to ascertain, but most of the data suggests that motion preservation, whether it be disc anteriorly or TOPS posteriorly, reduces the adjacent segment stresses by 2/3. There's a 1/3 less likely chance.
Okay, I don't,
And
can
now
you,
you're showing contact information. Yes. Okay.
yes. So here's Jared's contact information. There are still many questions that are in the Q&A box that we can't get to. What I can suggest is anyone who would like to follow up, you can either follow up by contacting Shelbin at Premia Spine. Here's his email address, shelbing@premiaspine.com, with your questions. Or you can contact Jared directly. Here's his contact information here on the left. And we will, gladly follow up with any questions that you have. Jared, we want to thank you. Any final comments? There was one last question about Medicare and whether this is covered by Medicare. I don't know if you take Medicare or not,
Yeah.
but it would be helpful if you do know whether Medicare covers TOPS or not.
Yes. Yeah. So it's an evolving question in terms of whether we accept it or not accept it, but right now we are accepting Medicare, and Medicare actually does have a coverage indication for TOPS. The problem has not been Medicare. The problem has been based on region, hospitals, executives and price makers and hospitals who look at whether or not the hospital allows equipment into their service line. Some of the hospital, I mean, unfortunately, the majority of hospitals have actually said, yeah, Medicare will reimburse, but we're not happy with the reimbursement, so they're not allowing surgeons to do it, or they haven't looked at the data or don't understand the data, despite phenomenal randomized controlled trial data with the FDA showing superiority to fusion. A lot of these hospitals and networks have been slow to come online or cautious because of reimbursement problems. So most, and this is just so people understand my practice, most of our practice has actually been doing TOPS for people as an outpatient, which is certainly more expensive than if Medicare is covering it at a hospital, but it's much more affordable than if you're in a hospital paying for it out of pocket. So we've tried to find a balance. And I work almost daily at trying to get various hospital systems like the Providences and the HCAs and the Cedars and the UCLAs and all the big names and big groups to try and get coverage for our patients, even with Medicare coverage. And the PPOs and some of the private payers have been even slower to come online. But I wouldn't, I don't want people to be discouraged because this is the same thing that happened with artificial disc replacement. And I have a background actually. When I was at Harvard, I did grad work in healthcare economics. As a healthcare economist, a lot of my work is looking at cost effectiveness. And we proved a long time ago that 2-level artificial disc replacement in the cervical spine was cost effective and superior to fusion. And it took 2 years, but then Blue Shield and Blue Cross actually came out with this kind of widespread approval, and then everyone else followed. So there is always a delay to these things, and it's unfortunate and annoying, but we're fighting the good fight for our patients because we want people to have access. I will say, if anyone wants to reach out personally, the Instagram handle, I do my very best to get back to you personally and not have an assistant get back to you, but I apologize if there are any delays. And then if you want to reach via email, the office at NSG, Leslie is my practice coordinator and is very good at getting people kind of set up for Zooms or one-on-one meetings, and it actually can help you very easily often upload your imaging to our digital server. And the worst case scenario, you kind of courier discs or one of the old school ways, but we're usually able to do that for people.
Great. So I know you see patients that travel from all over the country to see you, which is fantastic. There were some questions about, is there a TOPS doctor close to me, and folks were writing from different parts of the country. So the easiest thing would be to write Shelbin, and then Shelbin can direct you to Jared's address. And if you want to stay local, he'll be able to give you names of surgeons that use TOPS locally. So we appreciate your time, Jared. We're a little over, so I apologize, but
no, it's a pleasure.
Certainly send your comments and questions, and we'll try to follow up with all the folks who didn't have their questions answered during
and I'm happy
session.
to be of service and help, even if coming to see me, if there's someone that you trust and is local that is comfortable with it and they think it's appropriate, I'm happy to lend advice. And I've taught lots of surgeons that have come to see me kind of do it as well. So always happy to be of assistance. It doesn't, there's plenty of people. I want this to whatever it takes to avoid unnecessary fusions. It doesn't always have to be me. I really want patients to get the right care.
Right. Thank you. Thank you very, very much. And thanks
Pleasure.
for participating. Take care, everybody.
All right. Take care. Take care, everybody.